current presentation will summarize elements related to risks during pregnancy through 2 points of view. One will be conditions that may complicate the pregnancy, while the second one will be pregnancy-related complications. Until not long ago, many women that were carrier of chronic conditions were unable to become pregnant, unable to maintain a pregnancy, or even survive giving birth. Now, there are huge advancements in treatments that allow medical specialists to manage better those conditions and allow women to become mothers. The care of a woman during the pregnancy, especially if she has a chronic condition, needs to be done by someone that is specialized and has advanced training in high-risk pregnancies. And this is an obstetrician that is named a perinatologist. Usually the perinatologist will consult with other healthcare providers. This usually are managing the chronic conditions of the woman when she's not pregnant, in order to both of them to manage both the pregnancy and the chronic condition in the best way possible for both the mother and the baby. We'll start with probably one of the most common condition in the Western countries, and that's diabetes mellitus. Diabetes mellitus is a chronic condition that involves the glucose metabolism, and the result of the compromised metabolism of glucose is either due to a lack of insulin production by the pancreas in type 1 diabetes, or by an ineffective insulin utilization by the body in the type 2 or the adult type. Especially if it's poorly controlled, this condition may adversely affect the pregnancy outcomes and especially the baby. So an interesting fact is the aspect of metabolism, the glucose metabolism that is changed and not necessarily compromised, but they change completely during pregnancy. And this is a result of some normal changes in the endocrine system of a pregnant woman, mainly related to blood glucose levels and insulin. And there are 3 aspects that will define what is called diabetogenic effect of pregnancy. And when we are looking at that, we are looking into 3 elements. That will be a blood glucose level that are lower than normal. They are called mild hypoglycemia when fasting. Will have blood glucose levels higher than normal, or a mild hyperglycemia after meals. And the third one that will be associated with the previous 2 will be the insulin levels that are increased, or hyperinsulinemia after meals. And all the 3 elements, what they do, they actually will increase the tissue resistance, the mother's tissue resistance to insulin, in order to ensure the fetus to have higher levels of glucose necessary for growth. So if we are looking to the diabetes mellitus, we have a few categories. We have what is called a type 1, a type 2, and we have a special type that is called gestational diabetes mellitus. So again, if type 1 is basically due to a lack of insulin in the body, and type 2 is increased insulin resistance, the gestational diabetes is more similar to the type 2. So regardless what type of diabetes the mother has, the treatment will not depend on the type, but rather on her symptoms. So we'll look into what is called a pregestational diabetes mellitus. So a pregestational diabetes is when the woman is actually entering the pregnancy. She becomes pregnant while having one of those 2 conditions, diabetes type 1 or type 2. Historically, we used to say that those women having a type 1 diabetes have a higher incidence of spontaneous abortions, of miscarriages, or if they are able to carry the pregnancy to term, the fetus was a high risk for congenital anomalies or would be a stillbirth. And again, with the modern advancements, both the maternal and the fetal outcomes nowadays are highly improved, and due mainly to a strict control of blood glucose levels and also a strict fetal surveillance and observing immediately any types of distress at the fetal level. However, whenever we have a patient that has a poorly controlled pregestational diabetes, when her diabetes even before pregnancy was not controlled in a good way, particularly if this is uncontrolled during the early weeks of pregnancy, that may predispose her to complication as birth defects or stillbirth or hypertensive disorders. Also to a condition that is called polyhydramnios, when there will be an excessive level of amniotic fluid or macrosomia. Gestational diabetes, on the other hand, occurs only during pregnancy, and somehow in the process of development, in the pathophysiological process, is very similar to diabetes type 2. And because if in diabetes type 2, the underlying mechanism is insulin resistance, is gestational diabetes is just the same one. So in gestational diabetes, the woman's body cannot tolerate the physiological changes that we described before in the diabetogenic effect of pregnancy. So I will give you a few of the risk factors that may predispose a mother for gestational diabetes, and those are the history of a large gestational age infant, a history of gestational diabetes in the past, previous unexplained fetal demise, an advanced maternal age, those women that are over 35 years of age, a family history of diabetes 2 or gestational diabetes, obesity, those patients that weigh over over 200 pounds, and see that we are looking more at the pounds and not that much of the BMI, non-Caucasian ethnicity, a fasting blood glucose over 140 milligrams per deciliter, or random blood glucose over 200 milligrams per deciliter. So we need to remember that most of those women that develop diabetes do not always experience symptoms. That's why the screening for gestational diabetes is a standard procedure in the prenatal care for all women and not only for those at risk. So how do we do this screening? So the screening is done at approximately 24 to 28 weeks of pregnancy. However, some of the healthcare providers may screen as early as 20 weeks if we have someone that is in a risk group. So if the woman had a prior history of gestational diabetes, the screening will start even at the first prenatal visit. The diagnosis of gestational diabetes is based on the results of an oral glucose tolerance test, or is also called the glucose challenge test. And the elements for a challenge test are as follows. The woman will present to the testing center after she was fasting since the night before. And the blood draw will be taken, and the result should be for a fasting patient under 95 milligrams per deciliter. A challenge glucose test will be given, and the woman will drink that, and 3 consecutive blood draws will be done at 1, 2, and 3 hours after that. The normal values need to be under 180 for the first hour, 155 for the second hour, and 140 for the third hour. We'll have a diagnosis of gestational diabetes mellitus if 2 or more values meet or exceed the levels that I gave you before. So a woman that developed gestational diabetes during pregnancy is at increased risk for developing a type 2 diabetes after, with numbers somewhere between 30 to 50% of those women developing diabetes within 5 to 20 years after delivery. Let's look a little bit what will be some fetal complications from maternal diabetes. Now, regardless of the type of diabetes, a fetus that is born to a mother with diabetes is at an increased risk for placental issues, for increased fetal growth, for hypoglycemia immediately after birth, for birth trauma because they are so big, lung maturity issues, and an increased health risk later in life overall. For the diabetic woman, she is an increased risk to have the need to experience a C-section at birth because of the highest sizes of the macrosomia of the fetus. Diabetes will cause damage to blood vessels and usually affects major organs like eyes, kidneys. So in pregnant women, the diabetes may affect the placenta's blood vessels. As a result of that, placentas will tend to be smaller with a maternal fetal circulation decreased. That as a result of that, the fetus may be exposed to what is called a chronic fetal hypoxemia, not enough levels of oxygen during their development, and as a result of that, a growth restriction. I was talking to you about the macrosomia, or the big size of the babies of mothers with diabetes. And macrosomia is defined of a birth weight over 4,000 grams or 8.8 pounds. And as a result of that, we can end up having a situation that is called pelvic disproportion between the size of the fetus and the mother pelvic rim. Sometimes they can end up having what is called a shoulder dystocia, and when the shoulder becomes stuck during a vaginal delivery. All those elements are the result of the fact that while insulin will not going to cross the placenta because it's a molecule that is too big, the glucose easily will cross. So when the patient's, the mother's blood sugars levels are elevated, large amounts will cross the placenta, and the fetus do not have the insulin resistance. The fetal pancreas will produce increased level of insulin to handle the high sugar levels, and at the delivery, the baby's pancreas is still used to secrete increased levels of insulin, and as a result of that, the baby will experience hypoglycemia repeatedly immediately after birth. So what will be some elements in terms of treatment and surveillance? So what will be the pre-pregnancy care? So any woman that is at childbearing age and has pre-gestational diabetes should make sure that her diabetes is very much in control before she becomes pregnant. A persistent hyperglycemia can be harmful to the growing fetus, especially during the first 8 weeks when all the organs are formed, and cardiac defects may occur as a result of hyperglycemia. Also, the woman needs to make sure that she's supplementing her diet with multivitamins, especially those that have folic acid, to prevent any type of neural tube defects. So the most important thing in terms of nursing intervention is to explain our patients that they need to have as a main goal of treatment to maintain a tight glycemic control throughout the whole pregnancy. And we'll do that by measuring the glycosylated hemoglobin, HbA1c, and this will determine the average blood sugar levels during the past 4 to 8 weeks by looking at the percentages of red blood cells that have glucose glycosylated, glucose incorporated in the hemoglobin structure. Whenever there are sustained periods of hyperglycemia, those will result in higher levels of hemoglobin A1c. So the goal for pre-pregnancy diabetic patient will be to have hemoglobin A1c at level of under 8.5%. During the pregnancy, the mother will have periods of fluctuating energy that depend on the different times of the pregnancy. To accommodate that, the woman will need to check her blood sugars frequently, more than usually, and will recommend that the common types to measure the glucose will be upon awakening, after breakfast, before and after lunch, before and after dinner, and before bedtime. And the main goal is to maintain a fasting blood glucose of less than 95 and to not exceed 122 hours after meals. So in order to help them to maintain a good glycemic index, we advise our patients that they need to um, be very careful and use insulin, diet, and exercise. In those patients, and I'm talking now about the pre-gestational diabetes patients, for those that they have the gestational type, the focus will be on diet and exercise. In terms of insulin therapy, while the blood glucose can vary tremendously throughout the gestation, we need to understand that the first few months, the woman's insulin requirements will fluctuate the most, and she will be at high risk for episodes of hypos, particularly between meals. And this is because the embryo is growing so rapidly now, and it's doubling its size so quick that this growth rhythm requires a constant supply of glucose, and this will deplete the maternal blood of sugar levels. So at the beginning of the second trimester, as opposed to that, the insulin requirements will stabilize. What I forgot to mention is that in the first trimester, most of the time, the glucose needs will decrease because of the high consumption at the level of the embryo. At the beginning of the second trimester, the insulin requirements will stabilize and then begin to increase again around 24 weeks of gestation, and they will continue to increase until term. During labor, however, the insulin needs will become variable again, and in the first 24 hours after delivery, also the insulin requirements will fall dramatically. So for the patients with type 1 diabetes, the woman may self-administer insulin through a scheduled subcutaneous injection throughout the day, or she may use an insulin pump. Whenever the diet and exercise will fail to keep the fasting glucose levels lower than 95 or below 122 hours after a meal, we can recommend even to a patient with gestational diabetes to use an insulin pump. We'll talk now about the oral hypoglycemic agents. So historically, those agents were discouraged during pregnancy, especially due to the fear that this type of medication can have a teratogen effect on the fetus. Glyburide and metformin, however, have been shown to be effective in management of blood glucose during pregnancy as possible insulin alternatives for those women with diabetes. And in very short-term studies, not on extensive studies, they have been shown to be safe, and they need to be still evaluated in long-term effects. Regarding diet, another important part of diabetes management is the diet, and the goals of dietary intervention will be to supply the nutritional needs of the woman and the fetus while maintaining the blood sugar levels in the normal range, and by all means prevent the ketoacidosis. Usually the help of a registered dietitian will be required, and we prefer someone that has experience as a diabetic educator. We'll encourage our patients to exercise. This is important because in poorly controlled diabetes, we can have vascular damage and hypertension and renal insufficiency. We not only that we observe the mother, but we also need to keep an eye on the fetus, and this is critical. An initial sonogram will be done in the first trimester to determine the gestational age and the fetal viability. We do a second one that it will be a high level and more detailed at 18 to 20 weeks to look for any kind of structural defects, including heart fetal defects. We also measure amniotic fluid volumes. Maternal alpha fetal protein levels will be also measured at 16 to 20 weeks in a way of screening for neural tube defects. If we have a patient with hemoglobin A1C levels that were elevated in early pregnancy. We'll do also a fetal echocardiogram to observe for fetal heart defects in second trimester. And we'll continue to monitor the size of the fetus throughout the third trimester because, again, they usually tend to have babies big in size that may require at a certain point a C-section for delivery. During the third trimester, most of the fetal surveillance will look to detect any type of fetal stress. So we are going to do both non-stress and biophysical profile for those babies. In some cases, we may prescribe a contraction stress test if the non-stress test is non-reactive or the biophysical profile is non-reassuring. In diabetes patients, there will be a need for determining the timing of delivery to find the optimum time and method. The challenge is to avoid fetal injury by allowing the fetus to mature fully, especially the lungs, because the elevated maternal glucose levels can delay the fetal lung maturation. And as a result of that, even if a fetus in terms of age of gestation may be at term, they may still be predisposed to respiratory distress. That's why in term 3, in some of the patients, we may decide that we'll need to do an amniocentesis to document the fetal lung maturity by measuring the ratio between the lecithin to sphingomyelin. In some women that have diabetes, we may try a vaginal delivery if the cervix is favorable and the fetal lungs are mature. If the pregnancy progress is too long, and as a result of vaginal delivery, we may have complication as shoulder dystocia or fetal demise, we may recommend a cesarean delivery to prevent those. So question 1 is asking, gestational diabetes is a form of diabetes mellitus that occurs during pregnancy. It is caused by insulin resistance. What is the result of gestational diabetes in a normal pregnancy? Blood glucose levels are higher than normal, mild hyperglycemia after meals. Blood glucose levels are higher than normal, mild hyperglycemia when fasting. Blood glucose levels are lower than normal, mild hypoglycemia after meals. Or D, insulin levels are decreased, hypoinsulinemia after meals. Overall, cardiovascular disease, and mainly heart disease, is the second leading cause of death in women of childbearing age, and will complicate approximately 1% of all pregnancies per CDC data. The common cause of heart disease includes congenital heart conditions and rheumatic heart disease. There will be significant changes that pertain to the cardiovascular system during a normal pregnancy, with blood volume and cardiac output increasing, the systemic vascular resistance dropping. In a normal and healthy individual woman, those changes will be easily tolerated. However, for those patients with any kind of heart or vessels involvement, those normal physiological changes will cause discomfort and may lead to cardiac failure. There will be cases when someone with an undiagnosed heart conditions with very mild symptoms may be newly diagnosed based upon symptoms that she will report when she becomes pregnant. The greatest risk for the pregnant woman with a cardiac condition will be the end of the second trimester, when the blood volume actually peaks and is overwhelming for the heart, or during labor. Also, the early postpartum period, secondary to all those fluid shifts, will be also critical for a heart that is diseased. Generally, those patients that are classified as class 1 or 2 will have a good prognosis during pregnancy. And in class 1, we have those that have a mitral valve prolapse, will have a small patent ductus arteriosus, a mild pulmonic stenosis, will be those patients that had an atrial or ventricular septal defect or PDA successfully repaired in their past, or those that they have isolated atrial and ventricular ectopic beats. Again, the prognosis for class 1 is very good, and there will be no increased risk for maternal mortality. For those in class 2, those include patients with repaired tetralogy of Fallot, with patients with arrhythmias, patients with unrepaired atrial or ventricular septal defects. There is an increased risk for maternal mortality. However, the pregnancy prognosis is still good. For those in class 3 and 4, those that they have class 3 will be a mechanical heart, an unrepaired cyanotic heart condition, or Marfan syndrome. And in class 4, we include the patients with severe mitral stenosis, pulmonary hypertension, and Marfan syndrome with a dilated aorta. The risk for maternal mortality will increase, and the pregnancy prognosis may be moderate or even poor for class 4. In some of those cases, the pregnancy is even contraindicated. In terms of clinical manifestation and diagnosis, it is the pre-conception counseling is essential in this type of cases. We'll need to perform tests to evaluate the mother's heart function, and that will include an echocardiogram, a Doppler study, and a 12-lead electrocardiogram. Measurements of the maternal oxygen saturation being one of the most important predictors for both maternal and fetal outcome. In a mother with heart disease, signs and symptoms will depend on the type of heart condition. We may see tachycardia that may or may not be accompanied by dizziness or lightheadedness. And keep in mind that pregnancy is particularly dangerous for those patients that they have severe pulmonary hypertension. Usually an early warning sign of cardiac decompensation is persistent rales in the basis of the lung or pulmonary edema. The woman may notice also nocturnal cough, an inability to perform normal duties, dyspnea upon exertion, attacks of coughing with a smothering feeling, and even hemoptysis may be noticed. In terms of physical examination, we may found cyanosis, clubbing of the fingers, neck vein distension, tachycardia, heart murmurs, and edema, signs of that usually we'll look for in a patient with a heart condition. In terms of treatment, the treatment should be considered in a team approach, having along with the obstetrician, a cardiologist, and the perinatologist. The treatment will vary with the etiology of the condition, but they have some general principles that are common. We'll need to manage the activity, we'll need to provide stress management, diet, and medication. No matter how we are looking at this, the main goal will be prevention, early detection, and early treatment in any type of cardiac decompensation. The activity will be allowed as much as tolerated. The woman needs to be advised to rest frequently and to not allow herself to become overly fatigued. Because the heart becomes overworked during pregnancy, even in healthy patients, the bed rest is necessary and very important. Um, any unusual stress will increase the demand from the heart, and they may precipitate the heart failure. And stress is not just the emotional stress, it can be infection, anemia, dehydration, especially emotional and physical stress. We will recommend pneumococcal and influenza vaccinations to prevent those infections that can be sometimes harmful and fatal in someone with heart disease. Antibiotic prophylaxis to prevent endocarditis before any type of invasive procedure, just like in a normal heart patient. Diet will be particularized in a case by case. In some cases, the sodium restriction is helpful. The woman will need to continue to take her cardiac medication. However, there are some medications that are contraindicated in pregnancy as warfarin or coumadin, the angiotensin converting enzymes or ACE inhibitors, and angiotensin II receptor blockers or ARBs. Warfarin crosses the placenta and increases the risk for congenital anomalies. And as an alternative for that will be administering heparin to those patients. The heparin is a large molecule and it will not come across the placental filter. ACE inhibitors and ARBs can lead to fetal renal failure and increase the risk of newborn mortality. How do we manage a patient like that during labor and immediately postpartum? So first of all, we need to remember not to place any patient that is pregnant, but especially someone with heart disease flat on her back. We will always use a pillow or a weight or wedge under one hip when she is semi-recumbent. So during labor, because the cardiac output will increase, this will place the patient to risk for decompensation. So first we will avoid the supine position that will cause what is called the supine hypotensive syndrome that may, as a result, have a decreased placental perfusion that can compromise the fetal health. In this case, will also this type of condition may also require an amniocentesis to determine the fetal lung maturity in order to sometimes have an early delivery for this type of patients that mainly in the third trimester can deteriorate. Vaginal birth, if possible, will be preferred. So the benefits of a vaginal versus C-section will include a decreased oxygen demand and a minimal blood loss and a less chance that the woman will have post-op complication because there is not a procedure such as infection or any kind of pulmonary issues. However, the C-section will be imposed by some certain elements as cephalopelvic disproportions or the presence of an aneurysm. We'll need to remember that the stress and pain of the labor may increase the demand of the heart. And as a consequence, the pain relief is a very important part of the labor management for someone with a heart disease. Also, during the second stage of labor, when we have those vigorous pushing using the Valsalva maneuver, those can lead to cardiac decompensation. Therefore, when we are managing the second stage of labor, we'll need to allow the fetus to descend without maternal pushing, and that's under the control of the birth attendant. The postpartum may expose to the woman to complication as hemorrhage, anemia, infection, or thromboembolism that may increase the risk for complications from the heart. So the most important nursing action throughout all those elements will be to monitor for signs of cardiac decompensation. Will be early identification of signs of pulmonary edema, any freckles in the base of the lungs, or complaints of nocturnal coughing. We may ask the patient about how many pillows she's using to sleep at night, or if she needs to increase the number of those to help her breathe easier. It's Important to emphasize again to the patient the importance to protect against infections, to avoid crowds, to avoid anyone with signs of respiratory infections, even the common cold, to avoid secondhand smoke that may increase the risk of later acquiring and contracting an upper respiratory infection. We'll emphasize the importance of frequent hand washing. We'll recommend and, if possible, administer the pneumococcal and influenza vaccination. It's also important for the woman to report all her providers the condition that she suffers from, including the dentist. We will teach our patients to lay on the side instead of flat on the back when she's resting. Whenever she can, she needs to put a wedge on the one hip to release the pressure from the great vessels. We will also inquire about illicit drug use and cigarette smoking. Please make sure that you do that in a non-judgmental way and educate the patients regarding cigarette smoking and how adversely both illicit drugs and cigarette smoking will affect the heart and increase the risk for vasoconstriction and cardiac decompensation further down the way. During the labor, monitoring pain is critical in order to administer the analgesia and to provide all the pain relief measures that will allow for not to overwhelm the heart. We'll monitor vital signs, both of the mothers and the baby. And it is essential to continue to observe for signs of cardiac decompensation in the immediate postpartum period and immediately report fever, any type of increased bleeding or decompensations. A pregnant woman with cardiovascular disease can usually continue to take her cardiac medication during pregnancy. What medication cannot be continued during pregnancy? A. Digoxin, B. heparin, C. hydrochlorothiazide, or D. Coumadin. Coumadin is a medication that needs to be discontinued during pregnancy, and this due to the fact that Coumadin may produce birth defects. Anemia. So anemia is defined as a condition that and in which the blood is deficient in either red blood cells, the level of the hemoglobin in the red blood cells, or in total volume. Per se, anemia is not a disease, but is a symptom of an underlying condition. And as I said before, depending on the type of anemia, this can be the result of blood loss, maybe the result of hemolysis, increased blood cells destruction, or a decreased production of RBCs. The most common cause of anemia during pregnancy will be the iron deficiency anemia, with other anemias as megaloblastic anemia from folate deficiency or pernicious anemia from vitamin B deficiency also observed. We also have those that are hereditary types of anemia as sickle cell anemia and thalassemia having some influence on the pregnancy. Iron deficiency anemia will be characterized by a reduced production of IBC due to a lack of iron. So the RBC that are still produced are very small. They are called microcytic, and they are pale in color, hypochromic. And because the pregnant woman has increased iron requirements, this is the most common seen type of anemia in pregnant women. As common signs and symptoms of anemia, we'll see tachycardia, tachypnea, dyspnea, pale skin, low blood pressure, headache, fatigue, weakness, and dizziness. In some cases, we'll encounter pica syndrome, the ingestion of non-food types of substances as clay, or pagophagia, frequent chewing or sucking on ice. And those are signs most commonly associated with severe iron deficiency. We define anemia any hemoglobin level that is less than 11 and the hematocrit level less than 33 during pregnancy. The treatment will be to increase the patient diet in iron and folate in addition to just iron. In addition to, we are giving iron, but we need to supplement it to vitamin C to improve the absorption of the iron at the level of the small bowel. In some cases, the iron injections may need to be ordered, and very rarely a woman may require blood transfusion. We'll consult, also we'll educate our patient in terms of what changes she needs to do in terms of diet and how to choose those diets, those foods that are high in iron. We'll recommend animal protein, dried beans, fortified grains and cereals, dried fruits, and any food cooked in cast iron cookware, because part of the iron will be transferred to the food and will be available for absorption. Drinking orange juice when she takes her iron supplements will allow for an increased absorption, and that's because orange juice has a high concentration of vitamin C. Do not forget, and I mentioned that before, to provide adequate amounts of folate, and that's also in fortified grains and dried beans and leafy green vegetables. We also need to specify and explain to our patients that iron supplements may predispose to constipation, and this may make some of our patients to stop taking the iron supplements. We'll need to teach our patients how to prevent constipation by maintaining adequate fluid intake and the high fiber diet, by exercising, and by establishing regular bowel habits in order to stay on the treatment with the iron supplements. A specific type of anemia is that caused by a condition that is known as sickle cell anemia, which is a hemolytic anemia as a result of an abnormal hemoglobin molecule. It's an inherited genetic condition that it manifests itself especially in those having a heritage, an African American heritage or Hispanic heritage. What's particular about this condition is that they may have acute exacerbation of the disease called crisis, and in a crisis, usually triggered by a stress like an infection or hypoxia or trauma or cold, exposure to cold. The abnormal hemoglobin that has the shape, instead of being a biconcave type of cell, it's a sickle cell. It has this kind of crescent type of shape. Becomes sticky and clump together. They will clog the capillaries, and as a result of that, by clumping inside, the blood flow will cause tissue ischemia and pain at the site of the blockage. In addition to that, the normal blood marrow is not able to produce enough RBCs to replace the damaged one, and as a result of that, anemia will happen. A pregnant woman with sickle cell anemia is at an increased risk for a decreased renal failure or stroke or heart dysfunction and even sepsis. Women with sickle cell anemia have a higher risk to have premature babies or small for gestational age babies. They may have several crises throughout the pregnancy, and depending on which area of the body will be affected, they will experience bouts of pain in the joints, in the bones, chest, and abdomen. They also experience all the unspecific symptoms of anemia, as fatigue and tachycardia and dyspnea. What we can do for those patients is to provide them support throughout the pregnancies, teaching them about maintaining adequate hydration to prevent renal deterioration in a crisis, to prevent stress and extreme cold, to prevent crisis, to wash your hands frequently and to avoid highly crowded areas, to decrease the risk of contracting an infection, and as a result of that, to have a crisis. Just like in other patients before, pneumococcal and influenza vaccinations are recommended to prevent infections. Asthma represents a chronic inflammatory disease of the airways, and the main characteristic of asthma is acute exacerbation of reversible airway obstruction. It can be severe, and it may have considerable effects both on the health of the woman and as the fetus, especially when the condition is uncontrolled or has severe attacks. A woman that has a poorly controlled asthma may have a higher incidence of preeclampsia, premature labor, or hemorrhage. And as a result of the condition, the fetus may be low for gestational age or a preterm baby. Whenever an acute asthma happens, not only in the pregnant woman, but in general, the respiratory rate will decrease. The patient feels short of breath, feels anxious. The typical expiratory wheeze will happen with retraction of the respiratory muscles. Sometimes we may see the cough and the chest tightness. So in this kind of patients, throughout the pregnancy, it is necessary to emphasize that they need to have a good control of their condition. The goals will be to prevent the acute episodes, control symptoms, and maintain as much as possible a normal pulmonary function to provide necessary oxygen to the fetus. In terms of maintenance care of the conditions at home, that will be self-monitoring of lung functions, proper control of the environment to lower the asthma triggers, and to maintain the medication therapy. The woman will be guided and helped to identify the triggers and to take all the measures to reduce them. In terms of medication, albuterol and corticosteroids are the front line, are the first line of therapy. Oral asthma medications are reserved only for the severe cases. There is one condition, a severe form of asthma that is called the status asthmaticus, and it can be potentially fatal. And it's a complication of an acute asthma attack. For this kind of cases, an aggressive treatment is needed that will include IV medication, sometimes early intubation and mechanical ventilation if needed. During labor, usually labor will not only exacerbate the asthma symptoms, and if needed, the woman can continue her regularly scheduled asthma medication. There is a need for adequate hydration and analgesia to minimize the risk for bronchospasm. Inside the epilepsy category, we include a group of neurologic disorders that have as a common denominator recurrent, unprovoked seizure attacks. Most of the women with epilepsy will have, at the end of the day, healthy outcomes. However, pregnancy in the presence of epilepsy can be a little bit challenging because most of the time the drug metabolism, not only for epilepsy medication, but in general, will change during pregnancy. And therapeutic levels for anti-epileptic drugs may change. Another major risk during the pregnancy from epilepsy may be the blunt trauma that may occur if a seizure episode will happen. And as a result of blunt trauma, a miscarriage can happen, or premature rupture of membranes, or placental abruption. There are some epilepsy medications that can cause fetal defects, as cleft lip or palate, cardiac, and neural tube defects. And that's why women that are on this type of anti-epileptic medication should be on birth control. So the preconception consult with a neurologist is essential for a woman that who wishes to become pregnant. The goal of controlling seizure with the lowest number of drugs possible, that's the main goal, while some of the drugs may be changed to others to lower the incidence of birth defects. The woman needs to wait at least 6 months after changing the therapy before becoming pregnant in order to stabilize the treatment and make sure that there is not an increase in the seizures. Folate supplements are essential at least 1 to 3 months before even trying to become pregnant and throughout the entire pregnancy to prevent the risk for neural tube defects. The screening for neural tube defects in the fetus will be done very early in the pregnancies. So epilepsy is not usually a cause for a C-section, and most women can have a successful normal vaginal delivery. However, in some cases, IV medication is needed to control seizures if they occur. The main problem in those conditions is for the provider to determine if the seizure is due to epilepsy or is part of the severe pregnancy complication as eclampsia. Just like we discussed before with asthma, in epilepsy, status epilepticus is an emergency complication with a seizure activity that continues over 5 minutes and sometimes up to 30 minutes after the treatment is initiated. Or a different type of definition would be for 3 or more seizures without full recovery between seizures. The treatment of this kind of condition will be to have 2 IV lines to administer benzodiazepines such as diazepam or Valium, emergency intubation if needed with mechanical ventilation. Again, education regarding a diet high in folic acid, supplements of folic acid and vitamin K are essential for a normal pregnancy. Infectious diseases. Those are a threat in more than one way. First, they may cause an illness that requires treatment, and it can be passed to the fetus and cause both an infection of the fetus or leading to birth defects. In all those cases, the main goal is to prevent those infections. We'll look at some of those, and the most discussed one will be what is called a TORCH. And TORCH is an acronym for a special group of infections that, when acquired during pregnancy and transmitted through the placenta to the fetus, may produce significant birth defects. T stands for toxoplasmosis. O stands for any other infections as hepatitis B, syphilis, varicella, and herpes zoster. R stands for rubella, C for cytomegalovirus, and H for herpes simplex virus. Usually, TORCH infections are routinely screened during pregnancy, and whenever the screening will start at the first visit and can be redone whenever the provider has a reason to believe that the woman may have get one of those conditions. I'm going to talk a little bit about toxoplasmosis, and this is an infection caused by a protozoan, and it is called Toxoplasma gondii. And transmission is via undercooked meat, unfiltered water, contaminated soil, or cat feces. And it's common in humans and usually will have no symptoms. However, when it's encountered during pregnancy, it will pass through the placenta to the fetus, and a condition called congenital toxoplasmosis may occur. And the newborn with congenital toxoplasmosis may present with hydrocephalus, chorioretinitis, a lot of ophthalmic and hearing issues. That's why for those type of patients, we'll advise pregnant women that have cats to have someone else clean the cat litter and for them not to touch it in order to prevent an infection with toxoplasmosis. If they don't have anyone that can help them with that, they should wear gloves wash their hands thoroughly before and after. Um, they should wear gloves also when working in the garden or doing any kind of yard work, because it's also encountered out there in the dust. Um, we may advise them to not handle any kind of raw meat or eat any kind of raw meat that is cooked under 150 degrees Fahrenheit. Hepatitis B and syphilis. Hepatitis B can be transmitted sexually or through contact with blood and body fluids, and it can be transmitted to the fetus through placenta or by contact with vaginal secretion and blood during delivery. Most of the patients, most of the people in US are now routine vaccinated during school age years and sometimes as adults at risk. So the neonatal infection with HPV is at very low levels in US. Syphilis is a sexually transmitted infection with a bacterium called Treponema pallidum. And this bacteria spreads through sexual contact or through any type of broken skin. The main symptom is a painless red pustule, which will appear within 2 to 6 weeks after exposure in a genital area, will erode. And what is very typical for it is that it's completely painless. It's a painless, bloodless ulcer called chancre. And because it's painless, most of the people may not even notice it. However, this chancre will shed infectious fluid, and that serves as a portal of entry for the bacteria. This type of infection may cross the placenta and cause an infection that congenital syphilis, depending on the stage that is encountered, may cause a spontaneous abortion or miscarriage, may cause fetal demise, intrauterine growth reduction, preterm birth, or congenital infection. In terms of birth defects, as a result of syphilis, we can see blindness, deafness. We have what is called the Hutchinson triad, characteristic for syphilis, which is will include inflammation of cornea, deafness, and notched teeth, very, very particular type of teeth. The newborn may have a vesicular or a bullous rash that is contagious because the fluid in the bulla are highly contagious and may not exhibit the symptoms immediately after birth. It may take weeks to months or sometimes years to develop. As a general rule, every pregnant woman is screened for syphilis by either RPR, or VDRL lab test. A positive screen will require more in-depth screening for Treponema pallidum, and proper treatment, which is a very simple one, is done with penicillin G IM, either as a single dose or a 2-dose series. It can be given during pregnancy. It's perfectly safe to use during breastfeeding. And for those individuals that are allergic or sensitive to penicillin, they may receive erythromycin. Penicillin is also the treatment of choice for the newborns with congenital symptoms. Varicella and herpes zoster. Varicella is causing the chickenpox, with the herpes zoster the recurrent form of the virus. The reactivation results in shingles. Both varicella and herpes zoster are both members of the herpes viruses. They spread by respiratory droplets, so they are highly contagious. Will incubate for about 2 weeks, and they are contagious for up to 2 days before the onset of the skin lesions. And this happens until the lesion crusts over. The herpes zoster will be usually localized as a rash within a dermatome, the area of the body that is supplied by a particular sensory nerve. The rash is very painful. Sometimes pain and a tingling or itching kind of feeling will precede the rash. Nowadays, we have immunization for varicella through the varicella vaccination. So the incidence of varicella zoster during pregnancy is very low. However, if it occurs in a patient that is not immune to it during the second trimester, um, the fetal symptoms will be low birth weight, scar-producing skin lesions, limb hypoplasia, and contractures. Another type of birth defects is that can be seen will be damage to ears and eyes and central nervous system, cognitive impairment, and seizures. For those patients that report an exposure to chickenpox or shingles, they need a serologic test performed to detect the antibodies. They can be treated with varicella zoster immunoglobulin within 10 days of exposure. The neonate also can be treated with the same type of immunoglobulin within 96 hours of exposure. Now, the best treatment will be definitely prevention. A woman of childbearing age who has not had chickenpox should be vaccinated and should avoid becoming pregnant at least 1 month after vaccination. Vaccination cannot be done in a pregnant woman. However, whoever is susceptible to the condition in the household of the pregnant woman should receive the vaccination in order to prevent acquiring it and transmitting it to the pregnant woman. Rubella, or the German measles, German measles, is a virus that causes a mild illness that usually occurs in adults and children. When symptoms occur, they are very mild with low-grade fever, a little bit of rash, lymphadenopathy. However, if it happens in a pregnant woman, the virus will cross the placenta and will cause either spontaneous abortion, stillbirth, preterm delivery, or congenital anomalies. Typical would be a hearing impairment that is caused by the congenital rubella, followed by eye disorders and heart defects. There is no cure for congenital rubella, and all the treatment is supportive and directed toward controlling the symptoms and complications. The best thing to do for rubella is to prevent it. Usually the women need to be vaccinated. All non-immune women should be vaccinated before becoming pregnant, or should wait at least 28 hours after the vaccination before becoming pregnant. Cmv Cytomegalovirus, it's a silent disease in most individuals, and most will have no symptoms or only very mild flu-like symptoms. Most of the adults by age 40 would have had this condition. Is a virus in the same family with the herpes viruses, and the transmission is through the infected bodily fluids, saliva, blood, breast milk, urine, semen. During the first trimester of pregnancy, if contracted, the infection will pass to the fetus and will cause severe birth defects as microcephaly and seizures, jaundice, and a rash. There is no cure for this condition, so prevention is the key. Pregnant women who have contact with small children need to have a very good hygiene, because usually it's very common in children. Although the CMV may be present in breast milk, the women may breastfeed, because while contracting during breastfeeding rarely will be causing a serious condition. Herpes simplex has two forms. The herpes simplex 1 and 2. They spread through direct contact. Usually the type 1 will cause oral herpes or the cold sores, while type 2 will cause the genital herpes, and can be transferred through direct contact. In a newborn, both of them may cause serious illnesses, with symptoms developing within 2 to 14 days after the exposure to the virus. The lesions may last longer if we do not perform any type of antiviral treatment. Usually the first attack is more severe than the subsequent attacks. In the majority of cases, the neonatal herpes is Herpes is contracted by contact with the active virus during the vaginal delivery, and only a very small percentage of fetuses will contract the infection in the utero. The treatment during pregnancy will include a 1 to 2 week course of therapy with acyclovir within the first episode of an infection with herpes. If the women have any type of lesion at the moment of delivery, the decision will be to transfer the vaginal to a cesarean delivery to prevent the baby from coming in contact with any type of virus in the birth canal. Included here, we have some sexually transmitted diseases as chlamydia and gonorrhea. With chlamydia being the most common STI, sexually transmitted infection in the US, and is called by the Chlamydia trachomatis. Most women who have chlamydia will have no symptoms, and this will delay the diagnosis of the infection. It is a very prevalent condition, however, it may be underreported due to the fact that it's most of the time asymptomatic. And sometimes if the symptoms will appear, it will be a little bit of vaginal discharge with abnormal, maybe vaginal bleeding and a little bit of abdominal pelvic pain. Will be detected by testing the urine or the cervical secretions. Chlamydia, contracted in pregnancy, exposes to an increased risk for spontaneous abortions or miscarriages, preterm rupture of membranes, and preterm labor. Chlamydia can be treated with antibiotic, usually erythromycin or amoxicillin. And in addition to that, the sexual partner of the individual also may require the treatment. Gonorrhea it's caused by a bacterium, Neisseria gonorrhea, and is the second most common STD in the United States. Gonorrhea is transmitted during sexual contact with the primary site of infection for women at the level of the cervix. The diagnostic is realized by taking a culture. The initial symptoms may develop within 2 to 10 days of exposure, may be mild. Treatment is usually with a combination of 2 antibiotics that will treat both gonorrhea and chlamydia because usually those infections will be associated. The treatment will include 1 IM dose of ceftriaxone or riboflavin along with oral azithromycin. This treatment is also acceptable for pregnant women. Untreated gonorrhea may lead to PIDs, infertility, ectopic pregnancies due to scarring of reproductive tract. The untreated infection with gonorrhea will increase the risk for preterm labor with an increased risk for the newborn for infections of the eye, ophthalmia neonatorum, newborn blindness. That's why the newborns will receive prophylactic ocular treatment within 1 hour after birth. We are continuing presenting infectious diseases with the HPV or human papillomavirus, which is the most common viral STI in the US, was spread by skin-to-skin contact, direct contact with bodily fluids during sexual activity. The virus will produce condyloma acuminata or genital warts and is the cause for cervical cancer. Most of the cases will be asymptomatic, so someone having the HPV infection might unknowingly pass the virus to his or her sexual partners. Condyloma acuminata will develop in clusters on the vulva, within the vagina, on the cervix, or around the anus. They can be very small or they can develop into large clusters of warts resembling a cauliflower. We may have an abnormal pap smear as a first indication of an HPV. The genital warts may also disappear without treatments. while the treatment will depend on many factors, including age, duration, location, extent, risk of scarring, pregnancy status. There are several medical treatments available, topical application of medication, or it can be a surgical removal through a variety of techniques, including sharp dissection, laser, or cryosurgery. Genital warts have a tendency to increase in size during pregnancy. They may result in heavy bleeding during vaginal deliveries, and there is a risk of passing the HPV to the fetus during the birth process. In very rare cases, the newborn may develop what is called a laryngeal papilloma from the HPV infections. The vaccination for HPV is nowadays available, will be administered in a series of 2 injections over the course of 6 months, will help protecting against cervical cancer and genital warts, and it's approved for both females and males between the age of 11 and 26. We prefer to administer that as soon as possible before they start their sexual life. Trichomoniasis is caused by an infection with Trichomonas. It's a one-cell protozoa. It will infect the urethra, vagina, cervix, other structures of the vulva. It may be passed to the fetus during vaginal delivery, but it's very rare. It may be a cause for preterm rupture of membranes in preterm delivery or low for birth weight. The treatment is oral metronidazole or Flagyl as a single dose. It's also available in vaginal suppositories and cream formats. HIV or AIDS. HIV is a condition that will affect the protective cells in the immune systems, leaving the body without the ability to fight against infections. The final form of the HIV infection of the human immunodeficiency virus is the acquired immunodeficiency disorder syndrome, or the AIDS. The transmission happens during unprotected sexual activities with an infected partner. It can be transmitted through both hetero and homosexual activities. The virus will enter the body through the mucous membranes, and that will include the genitals, rectum, mouth. Once infected, the patients will not gonna feel sick immediately and may transmit the virus to others for long periods of time. A woman with HIV during pregnancy has a high risk to transmit the infection to the fetus, both during pregnancy and during the childbirth process, and also during the breastfeeding. The treatment is done with antiretroviral treatment during pregnancy and childbirth, and the recommendation will be to refrain from breastfeeding to reduce the risk of transmission after. In terms of clinical manifestation, when that happens, when we are at the stage of having symptoms, the symptoms will include swollen lymph nodes, feeling tired, weight loss, night sweats, fever, persistent infections, oral, vaginal, severe oral or genital herpes infections. In terms of diagnosis, this is done by identifying the antibodies to HIV in the bloodstream. The treatment will have 2 main goals, is to prevent progression of disease in the mother and to prevent perinatal transmission of the virus to the fetus. The best way to prevent it is to prevent HIV infection in the woman, or to identify it as soon as possible before or during the pregnancy. The type of birth, vaginal or cesarean section, depends on several factors, including the woman's viral load, length of time embrace that have been ruptures, and the gestational age. In terms of treatment, the medication ZDV, the Retrovir, is one of the main medication therapy used. In terms of recommendations for infectious diseases, First of all, the woman needs to feel safe and reassured that the healthcare provider will protect her confidentiality. We need to uh, offer and provide our patients with all the information necessary. Inform about need for protection. Inform about the risk for any fetal complication from the infection. Inform about options in terms of treatments. And also observe the woman for a decreased self-esteem and address that if needed. Always keep in mind that a pregnant woman has, with a sexually transmitted infection, is an increased risk for preterm delivery, regardless of the type of the pathogen that is involved. Question number 3. TORCH is an acronym for a specialized group of infections that can be acquired during pregnancy and transmitted through the placenta to the fetus. Why is TORCH so important during pregnancy? And the options are A. Macrocephaly can occur. B. Can cause post-mature delivery. C. They are teratogenic. D. Can cause hepatosplenal growth retardation. And the answer is they are teratogenic. And all of those infections involved that can be involved in the TORCH syndrome may cause a variety of birth defects. We'll talk now about the intimate partner violence, and this is defined as any abuse that will be perpetrated by an individual against an intimate partner, with the main goal of the abusing behavior being to exert and maintain power and control over the partner. And this abuse will refer to any type of injury that can be committed against a person, and that will include physical, emotional, psychological, or sexual maltreatments. And I will give examples of physical abuse will be punching and kicking, slapping, shoving, biting, grabbing, choking, hair pulling, burning. Emotional acts of abuse will be threats to harm self, the intimate partner, or others. The silent treatment, or refusing to interact with the intimate partner without an explanation. Name calling, put downs, derogatory comments. Any act of control in terms of financial decision making, isolation from family or friends, prohibiting access to transportation or phone. Threatening or completing even acts of violence against pets or children, destroying property of the intimate partner, or blaming even the intimate partner of his or her violent outbursts. In terms of sexual acts of abuse, will be forcing the partner to watch or perform any sexual act against the partner's will. Now, we define an intimate partner, any person who is or who has been in an intimate relationship with the victim, and includes present or former spouses, boyfriends, girlfriends, or dating partners. So, in other words, this can happen in any type of relationship without regard to sexual preference. It can occur in any and all social, cultural, religious, and economic boundaries. There are other terms that will be included in the general term of intimate partner violence, and those will be domestic violence, spouse abuse, domestic abuse, or battering. Those are more used in a legal point of view. It is very hard to determine the exact rate of intimate partner violence, and this is because most of the cases will go unreported. And there are various definitions and ways of collect the information about it. Women are, in most cases, those that will report an abuse. However, men can be victims of intimate partner violence too. And pregnancy is a particularly vulnerable time for a woman. The intimate partner violence may escalate during pregnancy, especially if the pregnancy is unplanned. And there are some data that shows that up to 8% of all pregnant women will experience abuse at a certain point during pregnancy. And in some cases, the victims may even die as a result of the abuse. The pregnant woman is especially at risk for certain complications associated with the abuse, may be exposed to risk of hemorrhage or fetal growth restriction or even fetal death, premature labor, infections of the chorion and the amnion, um, delivering by C-sections. In most of the cases, the baby will be low birth weight at birth. So in terms of clinical manifestation, there is a certain sequence of 3 identifiable phases in the cycle of violence. We'll have what is called a tension building phase with an explosion phase, followed by the absence of tension or the honeymoon. How do we screen? Well, we need to screen every single one of our patients to identify victims. It's a routine screening for all the women. Will be direct questioning about abuse, and in particular, the prenatal period will be the excellent opportunity for that. There will be some barriers while you try to do the screening, and especially because the provider may be afraid of embarrassing or offending the woman. Some of the providers will avoid screening because of personal feelings or prior encounters with intimate partner violence victims. And also it can be difficult because a lot of times the victim may have with them the perpetrator. So it will be hard for them to really acknowledge or recognize in front of the provider. There will be some signs that may raise the suspicion of possible intimate partner violence, and those will be a history of repeated assaults, a drug or alcohol abuse, depression or suicide attempts, any type of injuries to head, face, or neck, loose or broken teeth, injury to the breast or abdomen, injuries inflicted by weapons, cigarette or rope burns, bite marks. Usually the patterns and distribution of injury will include areas normally covered by clothes. They will occur on both sides of the bodies, often on extremities, and will be defensive posture injuries, such as at the hands or feet that the victim is trying to protect herself against an attacker. You may see injuries that are in various stages of healing. Injuries may not match the cause of trauma that your patient will describe. You may see a history of spontaneous abortions or previous fetal death. Now, it's important to discuss the options with our patients and to develop a safety plan. The woman usually has 3 options: to stay with the abuser, to remove the abuser through an arrest or with a protective order, or to leave the relationship temporarily or permanently. The most important thing is for us to discuss the options and allow our patients to make the decisions. It's also part of the intervention that we need to have is to create and make sure that they have a safety plan. We may offer them hotline numbers as the National Domestic Violence Hotline, to ask them to have to pack a bag in advance, that they will have some cash, credit cards, clothes for herself and the children if she will live with the children and she has children. And this bag should remain with a friend or family member house. It will not going to stay in the household where she lives. She needs to have important personal documents readily accessible, as birth certificates, driver's license, bank account information, important phone numbers, core documents, copy of utility bills, and the most important, to make sure that our patient has identified a safe place to go. And that can be a women's shelter or other safe place. And there are resources in the community that we can offer to our patients. Always make sure that you document all your patients' responses when you're inquiring about intimate partner violence. If she denies, document denial. What is important to do is to quote the woman directly. Do not use terms as alleges, but just literally copy word by word what she said. If the woman is disclosing any type of violence, you need to be very supportive. Your statements, your responses need to be supportive. You need to emphasize that the abuse is not her fault. You may state it as, this is not your fault, no one deserves to be treated like that. I'm sorry that you've been hurt, I'm concerned about your safety. Those are all good examples. Be as objective as possible when you're documenting your data. If there are any physical indications of abuse, draw a body map and use any type of measurable terminology to describe each lesions you observe. Offer resources that may include office and hospital personnel with specialized training, advocacy groups, women's shelters, hotlines, child protective services, and even law enforcement resources. Tell whether the following statement is true or false. Intimate partner violence is a reality in our society. It is important to assess every pregnant woman for interpersonal violence because pregnancy is a very vulnerable time for a woman in a relationship where IPV is a component. The answer is true. Pregnancy is a vulnerable time for a woman. IPV may begin or escalate during pregnancy, particularly if the pregnancy is unplanned. Researchers estimate that 4 to 8% of all women experience abuse during. Another element that may expose a pregnancy to risk will be when we are looking to age-related concerns. So the typical childbearing age may start around age 15 and it goes through 44 years of age. However, nowadays females will become pregnant between 9 and 56 years of age. Both ends of this age spectrum may carry their individual high-risk issues, including morbidity and mortality, both for the mother and the fetus. We will look now about and describe a little bit the elements related to the pregnant adolescent. We define as adolescent or teen pregnancy, any pregnancy that occurs in a 19 or years of age or younger. The consequence of that is that young mothers usually to have lower education levels, high level of poverty, and they have documented or may participate in behaviors that may increase the risk for poor birth outcomes, is smoking, late sporadic or no prenatal care, failure to gain sufficient weight. So they may have more pregnancy complication as anemia, preeclampsia, eclampsia, chromosomal disorders, STIs. The adolescent pregnancy and birth rate steadily declined from 48 births per 1,000 females to 22 births per 1,000 females in 2012. Those are some data that were published in 2017. Personally, I think that those numbers changed drastically during between 2012 and now when we are in 2020. Racial disparities also exist in terms of adolescent pregnancy and birth rates, with African American and Hispanic being highly affected. So I was describing before that they will seek prenatal care later, often in the 3rd trimester, or they will not going to receive prenatal care at all. In addition, social situation and maturity level is usually low. Most likely they are unmarried, have less education. They will be a member of an ethnic minority and live in poverty. And as a result of those that may be unaware of basic body physiology, may be unaware of the pregnancy and the stages and the development of the pregnancy. The best treatment for this kind of situation will be prevention, with many healthcare providers actively involved in preventing adolescent pregnancy. Now, an important role for nurses and healthcare provider also in the pregnant adolescent treatment is to be her advocate by giving non-judgmental and supporting information. Treat the adolescents with dignity and respect, and provide and protect their right to privacy and confidentiality in order to make sure that our patients are making their choices without any type of coercion. In terms of nursing care, we'll need to address caring for developmental needs. Pregnancy does not change their developmental tasks. They just make them even more complicated. And according to Erikson's developmental stage, we are in the stage of identity, and the identity is that essential developmental task during this age. So we'll, as a priority, the pregnant adolescent needs to feel accepted by her peer group and focus on and usually they are focusing on their appearance. So adolescents usually are typically very self-centered, and it's very hard for them to consider the needs of others, definitely very hard for them to consider the needs of a baby. In terms of physical needs, the nutritional considerations have a high priority over here. They need to be able to identify healthy foods, how and what they need to eat in order to provide both for themselves and for the baby. Keep in mind that culture will highly influence food choices, so we need to consider the adolescent's cultural context when we'll educate them about that. They have a high risk for delivering prematurely. So one way in order to decrease the risk of becoming pregnant is to educate them regarding both birth control methods. And along with that, educate along regarding STIs and how those should be prevented. In terms of emotional and psychological needs, they are very complex at this stage. Added to the emotional demands of the pregnancy is the emotional and psychological needs of an adolescent. They have an increased risk for suicide. They need to include significant support from the people around them. There are pretty much everywhere in the community will be resources for the pregnant adolescent, and we'll make sure to refer them to those services. We'll need to stay all along, we'll need to stay non-judgmental and open-minded when dealing with pregnant adolescents. Any type of scolding or scare tactics or punishment will not be helpful or healthy interventions. We'll just push the adolescent away and do very little to resolve their real issues. Pregnancy, on the other end of the spectrum, we see more and more women in their late 30s and early 40s becoming mothers, and across the globe, we've seen women as old as 66 that were able to conceive due to assisted reproductive pregnancy techniques. Now, there are known risk factors that are associated with childbearing for any woman over age 35. Usually and normally, women fertility will naturally decline with age. Nowadays, by using assisted reproductive technologies, we are able to have an increased incidence of multiple fetal pregnancies as twins and triplets. However, a woman older than 35 has a higher chance to conceive a child with chromosomal abnormalities as a Down syndrome. It's also at a high risk for spontaneous abortion or miscarriages, eclampsia and preeclampsia, gestational diabetes, placental abnormalities, and ectopic pregnancies. Now, when we are looking at those women in their late 30s and early 40s, they are more educated, they have postponed actually their childbearing years, and they may deal now with fertility issues. However, they are most likely married, they have financial resources, and they have everything planned now for pregnancy. On the other hand, they are more likely to have chronic conditions now, as diabetes or hypertension. They usually will report more discomfort with pregnancy. If she's physically fit, um, she will not complain that much of excessive tiredness and distress. However, hormonal changes in pregnancy are often a cause of facial skin breakouts, even for women in this late age group. It's essential to have preconception visits and ensure that they are aware of all their physiological needs. All their chronic medical conditions are well balanced before they conceive. They should be offered genetic testing and counseling um, regarding the Down syndrome, trisomy 21, or trisomy 8 twin, which is Edwards syndrome, or 13, which is Papao syndrome. Genetic testings will include chorionic villus sampling or early amniocentesis in order to diagnose early those type of conditions. Also, we'll need to approach those women in a very unbiased and non-judgmental manner. Make sure that you are not making the mistake of labeling them as old pregnant women. No one likes to be called old. Neither they want to be reminded that they have an increased risk for associated late childbearing issues. So those need to be, all this information needs to be passed in a very professional way. Well, we'll continue now to discuss some pregnancy-related complications. And those will be the effect of pre-existing and sometimes acquired medical conditions during the pregnancy. Those conditions will place both the woman and the fetus at risk. We'll start by talking about the Hyperemesis Gravidarum, and this is a disorder of very early pregnancy, and it's characterized by severe nausea and vomiting, resulting in weight loss, sometimes nutritional deficiencies, and definitely electrolyte and acid-base imbalance. It is happening in up to 2% of the pregnancies, with a higher incidence for those underweight and younger women. Usually it happens between week 8 and 12 of pregnancy. Usually it resolves by week 20. The exact cause is not necessarily clear. There is, however, an association between the symptoms and a high level of human chorionic gonadotropin. And this is because the risk of presenting hyperemesis is increased with a multiple gestation, a molar pregnancy, or when the patient had a history of previous pregnancies with hyperemesis. Contributing to that can be stress and psychological factors. In terms of clinical manifestations, we need to make sure that we distinguish between the typical morning sickness, because in the hyperemesis, the nausea and vomiting are very severe and may result in dehydration and, as I said, weight loss and electrolyte imbalances, particularly the hypokalemia. So before we put a diagnosis of hyperemesis gravidarum, we need to exclude other conditions that may be more critical, as hepatitis, hyperthyroidism, or disorders of the liver, gallbladder, or pancreas. An ultrasound is always done in order to rule out a molar pregnancy. Our patients will come with signs of dehydration, poor skin turgor, postural hypotension. Very rare esophageal tears and perforation can happen due to forceful vomiting. In terms of treatment, we can try non-pharmacological treatment of avoiding triggers like odor or heat or IMA preparation. We'll educate our patient in eating frequent and small meals, consuming peppermint teas or candy, eating cold foods that are not spicy or not having a very strong odor, We can try alternative therapies as hypnosis, acupuncture, acupressure, ginger, as in lollipops or tea, has good effects. For those that all those non-pharmacological measures are not helping, um, we may need, for those with severe dehydration, we may need to end up by hospitalizing the patient to correct the fluid and the electrolyte, as well as acid-base imbalances. Typical, the treatment will be IV solutions to treat the dehydration. We'll add glucose for a source of energy. We'll supplement with electrolytes and multivitamins. Our patients will be, if hospitalized, will be NPO for the first 24 hours or until the vomiting stops. Pyridoxine or vitamin B6 has been shown to be helpful in decreasing nausea and vomiting. Antiemetics can be prescribed. They become more effective if they're given on a regular round-the-clock type of schedule versus as PRN. This medication can be given parenteral or as suppositories until the vomiting is under control. Once the vomiting is under control, they can be taken by mouth. In some cases, steroid therapy can be helpful in those intractable cases. And in very rare cases, the one may require enteral feeding or parenteral nutrition. So during this time, we will monitor for nausea and administer the medication as ordered. We'll record the intake and output as well as weigh the woman daily, monitor the signs of dehydration and observe for the potassium levels as ordered, because hypokalemia can result from severe vomiting and may increase the risk for cardiac arrhythmias. We'll monitor the fetal heart rate, at least one per shift, and we'll remove and make sure to avoid any type of triggers. Also, we'll need to observe family dynamics because sometimes there are psychological factors that can contribute to this disorder. And in those cases, the woman may benefit from discussing the condition with a psychiatrist, psychologist, or with a social worker. Although there is not a clear understanding of what causes hyperemesis gravidarum, several conditions have been linked to it. What is one condition that has been linked with hyperemesis gravidarum? Single pregnancies, older mother, molar pregnancy, or obesity? Correct answer is molar pregnancy. The risk of hyperemesis is increased with a multiple gestation, pregnancy with more than one fetus, molar pregnancy, or when is a history of hyperemesis gravidarum. We'll discuss now a few of the bleeding disorders that can occur during early, mid, or late pregnancy. The early bleeding disorders will include the ectopic pregnancy and the spontaneous abortions. Diagnosis of molar pregnancy is most commonly in early pregnancy, but it cannot be identified sometimes until mid-pregnancy. Placenta previa and abruptio placenta are bleeding disorders that will happen during late pregnancy. Ectopic pregnancy. Ectopic refers to any object that is located away from an expected site of position. When we are talking about ectopic pregnancy, there is a pregnancy that occurs anywhere outside the uterus. The fertilized ovum will implant in another location, and it can be anywhere in the abdominal cavity, ovaries, cervix, and the most common place of implant will be in 98% of the ectopic pregnancy will be the fallopian tube. There is an estimation that up to 1% of the pregnancy will be ectopic pregnancy. Now, there are some factors that will influence the development of an ectopic pregnancy, and those are factors that will prevent the fertilized egg from traveling down the fallopian tube. So it plants before it reaches the uterus. Any type of adhesions or scarring or narrowing of the fallopian tubes may block the zygote process throughout the fallopian tube into the uterus. An example of conditions that may increase the risk will be the salpingitis or infection of the fallopian tubes, endometriosis, PIDs, history of prior ectopic pregnancies, any type of tubal surgery that was reversed, or multiple elective abortions. In terms of signs of symptoms, usually symptoms will appear around between 4 and 8 weeks of pregnancy after the last menstrual period. Usually, women will seek for help around week 12. Most commonly, they will seek help for pelvic pain or vaginal spotting. They will also present and will let you know about breast tenderness, nausea, and vomiting. Very rarely, the woman may present with late signs such as shoulder pain or hypovolemic shock when one of those tubal pregnancy will rupture and there will be a bleeding inside the abdominal cavity. So the diagnosis is critical to prevent the rupture and the profuse bleeding. The bleeding can lead to hypovolemic shock. Whenever there is hypovolemic shock, we'll see a rapid, thready pulse, a rising respiratory rate, shallow, irregular respiration, a falling in blood pressure with pale, cold, clammy skin, and decreased or absent urine output. The diagnosis may not be always very easy to make. However, the moment that we perform an ultrasound or a CT scan in some cases, the diagnosis can be easily be done. Definitely a serum or urine pregnancy test will help in detecting the presence of HCG. Laparoscopy can be performed to confirm the diagnosis and also to solve the issue. The treatment for the ectopic pregnancy, to finish the previous slide, the management will be depending on the woman's condition. Most of the time, it will be surgical. That will be the removal of the pregnancy, most of the time by salpingectomy, removing the whole fallopian tube together with the pregnancy, and making sure that any type of bleeding vessels are sealed. Early pregnancy loss is probably one of the most common complications of pregnancies, and is defined as we have a few definitions here. We have what is called a spontaneous abortion, and that will be a loss of pregnancy before 20 weeks of gestation. So the common name for an early pregnancy loss will be miscarriage. Abortions will be classified according to whether or not the uterus is emptied or for how long the product of conception is retained. It's hard to define exactly what is the rate of early pregnancy loss because many losses will even occur before the woman realizes that she's pregnant. So from the number of patients that present for medical help, probably 8 to 20% they will occur during the first trimester. The risk for spontaneous abortion will increase with advanced maternal age, history of previous spontaneous abortions, smoking, alcohol, substance abuse, uterine defects, and tumors. Most of the time, it's difficult to determine what exactly caused the miscarriage. Fetal factors are usually genetic, and because there are 3 overall categories: fetal, maternal, and environmental. So the fetal factors are usually genetic in nature, and as a result of chromosomal defects, the spontaneous abortion will take place in the first trimester. A faulty implantation, a defect in the sperm or the ovum are the most common causes. We make sure to use the term miscarriage when we are talking with most of our clients, because the term abortion most of the time will carry negative connotations for many of them, and we need to be sensitive to their feelings. Among the maternal-related causes, will be the advanced maternal age, autoimmune conditions, uterine anatomic abnormalities or fibroids, cervical incompetence, infections, endocrine dysfunctions, coagulation disorders. In terms of environmental factors, those will be poor nutrition, exposure to tobacco, chemicals, or radiation, use of alcohol, street drugs, or even prescription drugs. Typical manifestation of a spontaneous abortion will include cramping or spotting or up to frank bleeding, and the woman may expel blood clots or tissue. Usually they will complain of an abdominal or suprapubic pain that may radiate to the lower back. Sometimes when there are signs of sepsis, fever and chills may be present also. Now, any type, as a general rule, will consider any woman of childbearing age with a vaginal bleeding, will consider her pregnant until proven otherwise. So we have 6 types of spontaneous abortion, and we classify them in terms of clinical manifestation and treatment. We have what is called threatened abortion. Will be a vaginal bleeding or spotting with some cramping, no cervical dilation, and symptoms may resolve and the pregnancy may progress to term, and everything can be fine as long as we have what is called vaginal rest, no sexual intercourse, tampons, douches, bed rest, and only light activity is permitted. We have what is called an inevitable abortion, with cramping and spotting and vaginal bleeding with cervical dilatation and amniotic fluid that leaks. And we have 3 options. We can do what is called an expectant management, wait for the miscarriage to occur on its own. We can offer cytotec or misoprostol that is given orally and will induce contractions to remove the remaining of the product of conception, or we can do what is called a DNC, surgically removing the pregnancy. We have incomplete abortions. Some, but not all of the products of conception are expelled. Most commonly, the fetus will be expelled, but the placenta and membranes will be retained, and the only acceptable treatment will be to perform a DNC. We have what is called a complete abortion. All the products of conception, fetus, membranes, placenta, everything is expelled, and usually surgical procedures are not necessary so far, and the woman can go home with instruction to monitor for any type of complication as heavy bleeding or fever. We have the 5th type will be a missed abortion when the fetus dies but stays in utero. There are still signs of pregnancy, but the fundus is not growing and no fetal heart tones are present. With the ultrasound confirming the diagnosis, the only treatment available will be a DNC to eliminate the product of conception and prevent any type of infection. We have also the habitual or recurrent abortion, and this is the loss of 3 or more consecutive pregnancies before the fetus is viable. In those cases, what we need to do is not only the treatment for this present condition, but also we need to determine what is causing this habitual type of abortion. Is that cervical insufficiency, or is that fibroids? Because that will, by treating the cause, will be able to allow this a woman to have children. Make sure that you address the element of grief, because that is expected, and allow the woman and the partner or the support person to discuss their feelings with each other or with anyone else if they feel that that's what they need to do. We may need to offer the parents the opportunity to view the fetus if they desire. And it's important for us to acknowledge the loss. We should avoid any type of statements as you can always have more babies, or it wasn't his time to be born. That's non-therapeutic, and it will not going to help anyone. So early pregnancy loss, commonly known as miscarriage, can occur for a variety of reasons. What is one of those reasons? First, pregnancy active maternal infection, young age of mother, or multiple pregnancy. The correct answer is active maternal infection is one of the factors that increase the risk for spontaneous abortion. Cervical insufficiency, this is a condition that represents an incompetence or an incapacity of the cervix to maintain the pregnancy. During this condition, the cervix will painlessly dilate with the fetal membranes and sometimes parts of the fetals bulging out through the external os or opening of the cervix. Usually it occurs in the second trimester, and the pregnancy loss, if not treated immediately, is frequently inevitable. This may be considered the leading cause of recurrent mid-pregnancy loss. We don't have a good reason for a good cause for this condition. There are several risk factors: congenital defects of reproductive tract, a short cervix, history of trauma to the cervix as related surgery to the cervix. The standard treatment, however, is what is called a cervical cerclage, is the placement of a purse string type of suture in the cervix to keep it from dilating, kind of stitching it up. It will be done between 14 and 26 weeks of gestation, and sometimes it's done as an emergency procedure to maintain the pregnancy, and will be removed when the pregnancy is at term to allow for a normal vaginal delivery. Gestational trophoblastic disease will include two related diseases, both of them related to the trophoblastic tissue, the tissue that ultimately will form the placenta. And those two conditions are the hydatiform mole or the molar pregnancy, that is a benign growth of a placental tissue, and the gestational trophoblastic neoplasia, that is obviously a malignancy of the uterine lining. And we have two types of molar pregnancy. We have that is partial and one that is complete. And in both of those, we'll have error in the chromosomal duplication during the fertilization. As a consequence, instead of developing as a normal fetus and the supportive structures, what the product of conception will develop as a grape-like, a hydatiform swelling of the chorionic villi and a trophoblastic hyperplasia. When there is no fetus, that's called a complete mole, while when there is some fetal tissue with chromosomal abnormalities, that will be called an incomplete mole. So the molar pregnancy has some malignancy types of features because the trophoblastic tissue proliferates and multiplies out of control. In fact, about 1 in 5 of the women that will have a complete molar pregnancy will develop neoplasia within 6 months to 1 year after the molar pregnancy. The rate of hydatiform mole is 1 per 1,200 pregnancy in US, and a history of a previous gestational trophoblastic disease will increase the risk for a complete mole. As risk factors, we have either extreme ages or as young women or those that are older than 40. The diagnosis is put by examining a woman that usually will present 8 to 6 weeks, between 8 and 16 weeks of gestation, complaining of a painless brown to bright red vaginal bleeding. It can be intermittent or continuous, and they can be up to severe in terms of flow. Usually the HCG levels are unusually high, more than expected for the gestational age, and by performing an ultrasound, either transabdominal or transvaginal, the mass that is made up of many small cysts that looks like a grape will will put up the diagnosis. In terms of treatment, if the woman is coming up with a profuse hemorrhage, to stabilize the patient is the main factor, and she may require IV volume expanders and even blood transfusions, a correction of any type of coagulation disorders if they are present. If she's in a stable condition, surgery is the treatment of choice. We'll need to have a chest X-ray While this is the most common site of metastasis, the blood samples will show a baseline of HCG levels, and this is needed to perform the follow-up after the procedure will be done. We need to have those patients cross-matched because this procedure may lead to major bleedings. The evacuation of the uterus will be done by suction curettage if the woman will like to have children in the future, or abdominal hysterectomy if she doesn't want to continue her fertility. The follow-up will be continued up to 1 year in order to check for the ACG levels and to monitor to see and detect as early as possible any malignancy that needs to be treated early because it's highly treatable if it caught early. A young woman has delivered a molar pregnancy. You are giving her discharge instructions. When she asks you why she has to have blood drawn every 1 to 2 weeks by her primary caregiver, what is your best response? A, to detect malignancy, which is treatable if caught early. B, to make sure you don't develop ovarian cancer. 3, most women with a molar pregnancy get cancer during the following year. Or D, to detect any precursors to a malignancy. Correct answer is A, to detect malignancy, which is treatable if caught early. Placenta previa is a condition in which the insertion of the placenta or implantation of the placenta will be very close to or even cover the cervical os being the opening of the cervix. Normally, the placenta will implant in the upper uterine segment, and you see in the picture on the left side, that's the normal one, and you see on the right side, the abnormal one. As the pregnancy will progress, the blood vessels in the part of the placenta that covers the cervix may rupture and may cause vaginal bleeding. The exact cause for development of placenta previa is not known. Some may are describing potentially scarring or damage of the uterus that may increase the risk. If the scarring is present, the embryo may implant in a site that is more favorable for placental development. Conditions that may increase the risk for placenta previa are an increased number or history of elective abortions in the past, multiparity, advanced maternal age over 35, a previous C-section or uterine incisions, maternal smoking, or prior placenta previa. Placenta previa is classified according to the degree to which it covers the cervix. Total placenta previa will be a complete covering of the cervix. Usually placenta previa that is total is associated also with a bridge presentation and the transverse lie. It is thought that abnormally located placentas will prevent the fetus from assuming the expected head-down presentation. Now, sometimes the placenta does not cover the cervix, but is located on the border of the cervix, and this is called a marginal placental previa. Sometimes the marginal or the partial previa diagnosed early in the pregnancy may become a normal implantations as the uterus enlarges. However, a complete placenta previa will never result to a normal implantation for delivery. As clinical manifestation may have a painless bright red bleeding that begins with no warning signs, and the bleeding may be light to severe and usually stops spontaneously. Those bleedings may start before 30 weeks of gestation, and for any pregnant patient, and that's a general rule, any pregnant woman that presents with painless bleeding, you are not allowed, not you, not the provider, not anyone, no one will do a digital examination of the cervix until we exclude the diagnosis of a placenta previa by a transvaginal or an abdominal ultrasound. And this is necessary because by digital manipulation of the placental tissue, we can cause an uncontrollable bleeding. Most of the time, this first bleeding episode may not harm the fetus unless it's usually severe. So we'll need to monitor the fetal heart rate and make sure that it's in normal limits. In some severe bleeding episodes, the fetus may become anemic, hypoxic, or even develop hypovolemic shock because of the blood loss and the decreased oxygen transportation to the placenta that is detached from the uterus. In terms of treatment, depending on the level of bleeding and on the stage of the pregnancy, if the initial bleeding does not stop or is massive, an immediate C-section is a life-saving measure for both the mother and the baby. If the initial bleeding stops and the fetus is still immature, full hospitalization with bed rest is indicated with IV access maintained. Blood transfusions are performed if needed. Non-stress tests are performed to monitor for fetal well-being, and can even do continuous electronic fetal monitoring during an acute bleeding episode. In some very well selected cases, the woman may go home after the bleeding stops, but she must have someone with her at all times that can immediately transport her to the hospital if the bleeding begins again. Most of the time, a C-section delivery is necessary in the cases with total placenta previa. If allowed to labor, someone that has a total placenta previa will incur massive hemorrhage because the placenta blood vessels will break when the cervix is opening and when the cervix dilates. In terms of care, the placenta previa will require very careful nursing observation with IV access continuous and monitoring both the IV access and the vital signs, both of the mothers and the baby. The postpartum care of a woman that had a placenta previa is no different than the postpartum care of any other woman. However, they may be of an increased risk for infection and postpartum hemorrhage. Abruptio placentae, or a placental abruption, is the premature separation of the normally implanted placenta, with an incidence of about 1% out of all pregnancies. The placental abruption happens in placenta that are normally located. However, they prematurely pull away from the uterine wall, either during pregnancy or before the end of the labor. The cause is unknown. However, there are associated risk factors as elevated blood pressure, preeclampsia, or pre-existing chronic hypertension. Advanced maternal age, older than 35, and multiparity will increase the risk. Also, cigarette smoking, alcohol consumption, any type of trauma. A placental abruption can be classified in a few ways, and the bleeding is either concealed or hidden or obvious apparent, and the degree of abruption is either partial or complete. If the middle portion of the placenta separates, but the edges still stay attached, keep in mind that the placenta is round. So if the middle separates and the edges remain attached, the hemorrhage may occur behind the placenta, but the bleeding may remain concealed. Whenever a small edge of the placenta may pull away from the uterine wall, then the bleeding may be apparent and obvious. The signs and symptoms can range from hemorrhagic shock, DIC, uterine rupture, renal failure, and even death, both for the mother and the baby. Severity and the type of fetal complication relate definitely to the degree of the separation, if it's partial or total, and also the maturity of the fetus. In terms of clinical manifestations, we'll see signs of pain, dark red vaginal bleeding. Typical for this condition is a rigid board-like abdomen with hypertonic labor. It means with very hard contractions of the uterus and fetal distress. For any condition that either the mother or the fetus become unstable, an emergency section will be performed. After delivery of the fetus, the physician will control the bleeding. If unable to control the bleeding, the hysterectomy will be the life-saving procedure performed. Vaginal deliveries are always preferred to cesarean sections, especially for small abruptions, when both the mother and the baby are hemodynamically stable, or in those cases when the fetus demised. The contraindication for vaginal birth will include the fetal distress, severe bleeding to threaten the life of either the mother or the fetus, or what is called an unsatisfactory progress of labor. From a nursing point of view, the care necessary for any type of bleeding disorder that is encountered during the pregnancy, regardless of the stage and regardless of the uh, um, pathophysiology or the etiology of the condition, should focus on the following. Um, Maintaining placental perfusion and fluid volumes in order to avoid especially fetal injury. In addition to that, um, we need to focus on avoiding maternal injury by um, dealing with decreased perfusion to the maternal tissues and the hypoxia to the maternal tissues, along with maintaining a good perfusion and good oxygenation in the fetal tissues also. We'll need to prevent paternal injury by dealing with isoimmunization in those patients that may have a negative RH. All along to all those elements, we need to make sure that the nursing care plans will include all the necessary intervention to reduce the pain and the anxiety. One of the top 4 leading causes for maternal morbidity and mortality in US is the hypertension, and um, this disorder has an increased risk both for the mother and the fetus. We classify hypertensive disorders based on the moment of diagnosis, presence or absence of proteinuria, presence of proteins in the urine, and whether or not the condition will resolve spontaneously after delivery. Based on that, we have 4 categories of hypertension. We have what is called gestational hypertension, and this is defined as an elevated blood pressure, systolic over 140 millimeters mercury, or diastolic over 90 millimeters of mercury, that develops for the first time during pregnancy after 20 weeks of gestation. And this is without, I emphasize, without the presence of protein in urine. Gestational hypertension will resolve spontaneously after the baby is born, in which case will be classified as transient hypertension. If the blood pressure remains elevated 12 weeks after delivery, then the diagnosis will become chronic hypertension. Now, the main concern is that a gestational hypertension, or this kind of simple type of hypertension, may develop into a more serious condition that is called preeclampsia-eclampsia syndrome. Therefore, for every single visit, the urine will be checked for proteins and the blood pressure will be monitored very, very close. Now, we are moving into the next type of hypertension, and this is called preeclampsia-eclampsia, and that's a serious condition. And again, the pressure, the normal blood pressure will rise and will reach values over 140 millimeter mercury systolic or 90 millimeter mercury diastolic on 2 separate occasions, and this time will be accompanied, and I emphasize, will be accompanied by proteinuria, the presence of protein in urine. Preeclampsia may develop into the serious type of hypertension or the complication that is called eclampsia, when there is a presence of seizure activity or coma in a woman that previously had preeclampsia. Signs and symptoms of preeclampsia will usually appear after the 20 weeks of gestation and will resolve when the pregnancy will terminate. And the syndrome may develop gradually or may be suddenly diagnosed in a patient that had no warning signs before. We do not know the cause for the disorder to develop, the underlying etiology. Preeclampsia occurs only in pregnancy, and we don't know what causes this type of hypersensitivity. We do believe that is a result of an increased vasoconstriction, of vasospasm that happens at the level of the arteries, that will happen in every organ in the body. And as a result of that, hypertension will be produced. The elevated blood pressure will be perceived at the level of the kidneys, and as a result of that, the kidneys, as a result of a low flow at the level of the kidneys, they will secrete substances that will increase even more the pressure, will cause even a higher increase in the blood pressure. In other ways, will be an ineffective type of positive feedback instead of a negative type of feedback. In terms of risk factors associated with preeclampsia, how can we identify the patients at risk? Will be a family history of preeclampsia, eclampsia in those patients, nulliparity, this is the first pregnancy for them, pre-existing medical conditions such as chronic hypertension, systemic lupus, renal disease or diabetes, obstetric complication including multiple gestation, molar pregnancy, or carrying a fetus that develops erythroblastosis fetalis. Extreme age is also involved with patients younger than 20 or older than 35. Statistically speaking, up to 5% of pregnancy in the United States can be affected, and it's a leading cause for maternal death in underdeveloped countries, especially those where the prenatal care is inexistent, because the only way that we can literally and efficiently identify those patients is by screening them at every single visit. In terms of manifestation, again, the blood pressure will be greater than 140 systolic or 90 diastolic that developed after the 20 weeks of gestation, and will be documented on at least 2 different occasions, and will be accompanied by proteinuria that will be measured on a stick. They may also present with edema or weight gain. However, those are not criteria for diagnosis because edema occurs commonly in pregnancy and is not very specific to preeclampsia. However, if it's significant and is what is called non-dependent, not on the legs, not on the ankles, but it involves the face of or the hands, that's part of the preeclampsia signs. So depending on the symptoms, it can be mild or intermediate or severe. However, we cannot be blinded by the fact that if we say that the patient has mild symptoms of preeclampsia, those can develop very, very quick into severe signs and symptoms. So a patient with preeclampsia needs to be monitored all the time and very, very strict. Now, severe preeclampsia manifests with blood pressure over 160, over 110, with greater than 2+ protein in urine, and the symptoms will show elements of decreasing blood flow to all the tissues, especially to the brain. And while the brain is very sensitive to that, the nervous system irritability will be exaggerated and will result in hyperactive deep tendon reflexes and clonus. Severe headache may be associated and may indicate presence of cerebral edema. We may see patients with retinal edema that will report blurred or double vision and spots before their eyes. There will be visual changes and severe headache. Those are the hallmarks that may need to make us think about an impending seizure to occur. Whenever the patient shows up with a convulsion or a coma, that means that they are at the stage of exhibiting eclampsia. Typically, the seizures are generalized tonic-clonic in nature, only rarely will progress to a status epilepticus, and potential complications of those will be aspiration, cerebral hemorrhage, stroke, hepatic rupture, abruptio placentae, fetal demise, or even the death of the mother. They remain at high risk once preeclampsia is diagnosed. The patient will remain at high risk for seizure activity throughout the pregnancy, in labor, and even the first days after the birth in the postpartum period. There is another syndrome that is called the HELP syndrome. That is a severe complication of preeclampsia, eclampsia. But this syndrome may occur even in women that do not have proteinuria and that do not have elevated blood pressure. So HELP is the acronym HELLP is the acronym for hemolysis, elevated liver enzymes, and low platelets. This syndrome can be seen in up to 20% of the women with severe preeclampsia and increases the mortality rate during pregnancy. In terms of treatment, the primary goal of treating preeclampsia is to deliver a healthy baby and to restore the woman to a healthy state and to continues to have a normal blood supply and normal oxygenation to both the mother's tissues and the baby. Now, in management of the preeclampsia, the timing of delivery is essential because the only cure for preeclampsia will be to end the pregnancy. If the fetus is a term over 37 weeks, the physician may induce labor because always a vaginal delivery is preferred to a cesarean section. When the fetus is preterm, the management will depend on the severity of the disease and definitely based on the fetal lung maturity. The benefits and risk of conservative measures as bed rest and observation are weighted against the benefits and risks of a preterm delivery and management of a preterm baby. If the woman conditions will deteriorate rapidly or the infant will become unstable, definitely a life-saving procedure as a C-section may be considered. So in a conservative management, we allow a preterm fetus to mature and we closely observe the fetal well-being. The woman will be instructed to perform the fetal kick count after every meal because you know that increasing the glucose levels will stimulate the fetus. No-stress test is done at least twice weekly. In addition to that, at a certain point, an amniocentesis will be performed in order to establish the lecithin-sphingomyelin ratio that needs to be at 2:1 to indicate a lung maturity. If there is an imminent need for delivery and the baby is still preterm, the healthcare provider may order glucocorticoids, usually betamethasone, in attempt to increase or accelerate the maturity of the fetal lungs. Now, on the other hand, we'll try to prevent any type of maternal seizures. And if severe preeclampsia happens, the woman will be placed on bed rest in a dark and quiet room. Visitors will be restricted. Any type of TV, computer, or phone screen activity should be avoided to decrease the stimuli to the brain. The most effective medication in treatment and prevention of eclamptic seizure was found to be magnesium sulfate, and the will be administered IV. And the way that this drug works is by relaxing the skeletal muscle, and in addition is a central nervous system depressant that decreases the risk of seizures. So we can use magnesium sulfate in addition to other anticonvulsants as phenytoin or dilantin or diazepam, Valium. Now, the magnesium sulfate also needs to be closely monitored for signs of toxicity. The therapeutic level of magnesium is between 4 and 8 milligrams per deciliter, and this level is the one effective to prevent seizure without causing any type of toxicity. Toxicity is observed usually when the magnesium level reaches 9 milligrams, and the first sign of magnesium toxicity will be the disappearance of reflexes. In addition to that, respiratory depression and cardiac arrest can follow. So this is why it's essential to monitor the reflexes and the respiratory rate of a woman receiving magnesium sulfate very frequently. The antidote for magnesium sulfate is calcium gluconate. That's why it's a good idea to have the medication available by the patient bed. Preeclampsia can damage every organ in the body. We'll look especially at the kidney, and it's important because the urinary output needs to be measured hourly, and it needs to be over 30 milliliters per hour. Otherwise, it needs to be reported to the provider. Magnesium sulfate, in addition to its effect of relaxing muscles, skeletal muscle, will also inhibit uterine contractions. So if the delivery is indicated and the a woman will require oxytocin-induced labor, she will be at risk for postpartum hemorrhage because the uterine muscle may not be able to contract effectively and prevent or uh, contribute to closing of the arteries postpartum. So bottom line, the treatment of hypertension can be very controversial, and the changes can be very quick, and there are other medications that can be used in order to treat hypertensive crisis as labetalol or hydralazine, and they will be ordered by the provider as needed. The third type of hypertension will be the chronic hypertension, and this is the high blood pressure present in a patient before becoming pregnant. Um, if a woman has a pre-existing hypertension, the pregnancy is already at the risk because the sustained high blood pressure can damage the placental perfusion, leading to fetal growth restriction from the beginning. They are also at an increased risk for developing superimposed preeclampsia because they're basic high levels. The diagnosis is made just the same as for preeclampsia. The values are the same, 140 over 90, and that should be diagnosed at an age of pregnancy over 24 weeks of gestation. Question number 4, tell whether the following statement is true or false. One of the first signs of magnesium sulfate toxicity is an absence of reflux. The answer is true. Magnesium toxicity begins when serum magnesium levels approach 9 milligrams per deciliter. First, reflexes disappear, then, along with an increase in the levels, respiratory depression and cardiac arrest will follow. Multiple gestation is defined as any type of pregnancy that will carry more than one fetus. What is called a singleton gestation is typical for one fetus and is normal for the human beings. Twins are the most common manifestation of multiple gestation, and in general population, the twins will occur once in 250 deliveries, with triplets in 1 in 8,000 and quadruplets in 600,000 pregnancies in a natural case. Most of the pregnancies that are multiple gestation pregnancies will be the result of fertility treatments. The twins can be identical or monozygotic, resulting from one ovum, or fraternal or dizygotic, the result of two ova fertilized by two sperms. A woman has a high risk to conceive twins if she had twins in the past. Also associated with that would be an older maternal age, multiparity, or a family history of twins. When we are looking at monozygotic twins, those can have one or two placentas and one or two amniotic sacs. When twins will share a placenta, a serious condition that is called a twin-to-twin transfusion syndrome can occur, in which situation one twin that is called the recipient will receive more blood from the placenta than the other sibling. And as a result of that, one twin will develop way more than the other. The one that is called a donor will exhibit what is called an intrauterine growth restriction and will be severely anemic. Women with multifetal pregnancies have an increased risk for hyperemesis gravidarum, pyelonephritis, preterm labor, placenta previa, and preeclampsia, eclampsia. Also, the fetuses are at risk. They may be conjoined or experience growth restriction or be born premature. In multifetal pregnancy, there is an increased fetal nutrient demand. So patient carrying twins will require more calories, especially proteins, in order to ensure the necessary energy and materials for the fetal growth. In terms of nursing care, the prenatal care will be similar to that for a singleton pregnancy, um, in addition to that, will need to be a close observation of the pregnancy in terms of diet and fetal well-being. Yeah. And the mode of delivery will depend on several factors, and the most important one will be the presentation of each twin. In general, a C-section is indicated if twin A or the first twin is not in vertex presentation. So if the first one doesn't present in a normal way, it's probably impossible to have a normal vaginal delivery. If twin A is vertex, there is an option for vaginal delivery. If twin B is breech, the provider may schedule a C-section or attempt a vaginal delivery, but only if twin B is not larger than twin A. If twin B may experience fetal distress, or if there is a difficulty delivering twin B vaginally, a C-section is usually performed. Last thing that we'll discuss in this presentation will be blood incompatibilities, and those will be incompatibilities between the mother's blood and the fetus blood that will cause problems to the fetus. Normally, the two bloodstreams are not supposed to meet. However, occasionally, in some types of trauma, there will be some type of mixing of the two bloodstreams. And this is more likely to occur during invasive procedure as an amniocentesis. The risk also increases during active labor or spontaneous abortion, or when is a separation of the placenta during the birth. And we have two types of blood incompatibilities. One will be the Rh incompatibility, and the second one will be the ABO incompatibility. The Rh, or the D factor, is an antigen or protein that is found on the surface of blood cells. When this factor is present on the cells, which happens in 85% of the population, that person is called an Rh positive. And when the factor is lacking, the person is obviously negative. When a woman that is Rh negative is exposed to the Rh positive blood of the baby, such as in an incorrectly cross-matched blood transfusion, her immune system will produce antibodies to fight this antigen. Once those antibodies are produced, she becomes what is called sensitized to Rh positive blood, and this condition is called isoimmunization. So what happens if the Rh woman that is negative will carry a fetus that is Rh positive? If she was sensitized, her antibodies to the Rh factor will cross the placenta and will attack the fetus blood cells. The fetus will develop what is called a hemolytic anemia and will often require exchange transfusion in utero or shortly after the birth. Usually, those Rh negative women will become sensitized while carrying their first child. And the sensitization most often will occur during childbirth, when some fetal blood will leak into the mother's bloodstream during delivery. The standard procedure of treatment of those type of women will be to administer to sensitized women, and even to those that we don't know if they were sensitized, but we know that they are Rh negative and they are carrying an Rh positive baby, will deliver anti-D immunoglobulins within 72 hours of delivery of the Rh positive baby. In terms of clinical manifestation, what we'll see, first of all, we'll determine as a routine blood and Rh typing during the first prenatal visit, we'll see if there is any risk for an Rh incompatibility. And also, we'll look into the history of this woman and we'll see if she may have been already sensitized. She had any blood transfusions in the past? Did she have a baby before? So the treatment is to administer them RhoGAM, which is an anti-D immunoglobulin that will counteract the production of antibodies that the woman will produce. The ABO incompatibility is another cause for the hemolytic disease of the newborn. And the most frequently will arise when the woman's blood type is 0 and the fetus blood type is A, B, or AB. And this because type 0 blood has naturally antibodies that will act against types A and B and AB. And those antibodies are large and generally do not cross the placenta. However, occasionally they may leak into the maternal circulation, causing the woman's immune system to produce antibodies to fetal blood. Those antibodies are smaller than the natural occurring ones that are readily cross the placenta, where they work to destroy the fetal blood. Fortunately, this type of blood incompatibility usually results in a much less severe form of hemolytic disease than the Rh incompatibility, and rarely the babies will need an exchange transfusion.